Good morning, everyone. We'll start the second topic of today, which is anti-craving medications for alcohol-associated liver disease. This will be the outline of my presentation, where we'll discuss what craving is, the need for medications and for liver disease, and some gaps in literature, followed by the ILBS algorithm that we follow here. Okay, so this is how a normal alcohol use disorder management flowchart looks like, where it starts from short-term management of withdrawals, acute complications, and leads to long-term management, which is prevention of relapse. And this is where anti-craving agents, today's topic, comes into picture. Okay, so what exactly is craving? We'll start with that. In simple addiction medicine, craving is an powerful, irresistible urge for a substance which causes distress when not met. So this is a simple definition that is from an addiction perspective. It can be of a pleasure type, which is liking something and then looking for it, and the other is craving from wanting. The first one is from an opioidergic neurotransmission, the other is from the phasic dopamine release. In fact, phasic dopamine release has long been known to the most common biological basis of craving, when contextual or alcohol specific cues activate hippocampus and triggers memories associated with previous alcohol use, leading to increased dopamine neuronal activity in ventrotegmental area and ventral striatum, thus facilitating or reinforcing the behavior of alcohol use. But what they found in detox SPECT studies, which were done in people who were recently consuming alcohol, that there was also reduction in availability and sensitivity of central dopamine D2 receptors. Also, there was reduced intrasynaptic dopamine in the animals. So what they based on these PET studies, what they said, that unlikely that presentation of alcohol associated cues can cause a significant dopamine release. So this is the confusion that was existing in the field. And also in animal studies, they could not found that they found that craving existed even when no dopamine was released in ventral striatum. So then how can dopamine dysfunction contribute to alcohol craving and cue reactivity alone? So the answer was that dopamine dependent signaling of an error in reward expectation. Now reward expectation is glutamate driven. So what alcoholics or people with alcohol dependence have, that they are unable to divert their attention away from conditioned cues which motivate them for consuming alcohol. So there are other neurotransmitter systems involved, like GABAergic, but the important one is, which is being studied along with dopamine over the last decade or 2 decades, is the glutamatergic system, and most of the role has been found in triggering relapse, that memories induce release of dopamine, but that dopamine is, although not high than usual responses, but salience get attached to it through glutamate system. There's also cannabinoid and opioidergic systems. I'll not go into the details of these. We'll discuss them further. But let's just quickly review the types of craving and the accepted models of craving. One is the reward craving, where people have dopaminergic dysregulation or opioidergic. There, in these patients, there is generally positive family history. The other type is the relief craving, people who have chronic stress, anxiety, depression, and they end up consuming alcohol. This type of patient present generally late in their ages. And the third is obsessive craving, also known as, this is the most pure biological craving, where there is loss of control and just compulsive drinking. Patients will not be able to explain why they are consuming alcohol. So based on all this, the most accepted neuroadaptive model for alcohol craving is this, that chronic alcohol use leads to sensitization of dopamine receptors and opioidergic systems, which leads to change in neurotransmitters, which can cause, when initially abstained, like from hours to days, it can cause withdrawals leading to craving. And in the long term, the prolonged abstinence the memories of alcohol consumption can still remain and cause craving leading to relapse. So from that, let's move on to the topic of craving in liver disease patients. The commonly used terms from ASLD and EASL are MAUD, medications for alcoholic use disorder, and medications for addiction treatment. So as we all know that behavioral treatment are important and effective, then the The point is, then what's the point of giving pharmacotherapy? Then a recent paper of in Journal of Hepatology actually compared the two, and they found that counseling or non-pharmacological interventions were resource intensive and not accessible to many patients. It was costlier than a camprosate naltrexone. So they did a study on a 10-year retrospective basis and found that it provided fewer quality adjusted life years. The literature, they commented that literature is further limited by healthy user bias and confounded by selective prescribing. That is, that patients who are healthier are more likely to receive medications than those who have advanced cirrhosis. So out of the medications, disulfiram, camprosate, naltrexone are the FDA approved. Gabapentin, baclofen and topiramate are non-approved. But no medication has yet been approved for alcohol-associated liver disease. Mostly because most of these medication trials, CLD gets largely excluded because of metabolism concerns of hepatotoxicity. A study which was specifically done on baclofen, we'll talk about in the coming slides. So there is effectiveness in terms of abstinence, which thereby leads to reversing of liver disease. There are reduced risk of decompensation, reduced all-cause and liver-related mortality. Despite that, the rates of prescription have been as low as 1.4% in alcohol-associated liver diseases. In fact, the larger studies, 88 to 99% patients mostly receive behavioral therapy alone. So when they did intention to treat analysis on this cohort of 7 years, this was by the Siral group. So what they found was that in the first year after diagnosis of cirrhosis, there was 20% reduction, a reduced hazard of all-cause mortality. In fact, when they did a per protocol or as treated analysis, they found that up to 68% all-cause mortality, that is up to 2/3 mortality, was reduced in people who received any medication for alcohol use disorder. So the discrepancy is quite clear, that factors associated with good ALD outcomes are when MAUDs are given to all ALD cirrhosis in first year of diagnosis, when it is prescribed in an integrated setting through co-located AUD clinics, and when it is prescribed for 3 to 12 months with continued treatment. But when a larger group did a study on which patients actually ended up receiving MAUD, they found that the only factor that came significant was people who had an inpatient diagnosis of alcohol use disorder or hospitalization. This seems to be slightly different at ILBS, but majority places, this is what the norm is, that if patients have severe AUD or once they get hospitalization, only then they are given treatment. This is despite that till 2008, only less than 5% of alcohol-associated liver disease patients were on MAUD, which the trend of which is gradually increasing. But despite the increasing trend, when you look at the overall number of alcohol-related liver cirrhosis patients, the proportion of patients that receive MAUD still remains low. The Siral group also tried to answer a question that is complete abstinence necessary or reduced consumption can do the trick for liver disease patient. But what they found was, although reduction in alcohol consumption without achieving total abstinence was associated with better clinical outcomes in general population and even in patients with ALD, but specific liver related outcomes increased even with 1 to 7 glasses per week over 7 years in patients with pre-existing cirrhosis. So this is the trial that the retrospective cohort study that they reported from France and Belgium with 650 biopsy proven alcohol liver disease patients. Most of them were compensated, and what they found that 30% of them continued drinking more than 1 glass per week of alcohol, and in that group the hepatic decompensation rates were up to 15%. This is the survival benefit that they showed. The lower line is the non-medication line, the upper there is clear survival benefit over 10 years of treatment. So the comment on duration of use, they did a time update analysis and found that people who who took MAUDs for 3 to 12 months had better survival as compared to no MAUDs. The paper did not mention analysis of longer versus shorter duration, so that was probably missing. What they also interestingly updated was that any patient, when they saw a 30-day window period of any patient actively receiving MAUD, the chances of them dying at the end of study was less. So those who were on MAUDs were less likely to die. And this is what the survival graph of this analysis looked like, with 3 to 12 months being the best survival. So longer duration is important. Okay, so moving on to the next recent systematic review and meta-analysis just published a few months back in hepatology. So it was from 794 people, included studies on baclofen, metadoxin, FMT and acamprosate. The effect they found was that with medication there is reduced alcohol consumption and increasing alcohol abstinence by 30 to 32% compared to placebo or standard medical treatment. Safety, also they commented on safety, and they found that less than 3% patients had side effects which were possibly or probably related to study medications. The finding that was actually contrary to what has been studied in hepatology for the last 10 to 15 years is that for baclofen, the results in abstinence and results in craving were not statistically significant based on this meta-analysis. So let's move to specific medications, starting with the combined trial, the largest trial till date, always studied in and presented in all addiction-related papers. So what they found was that naltrexone appeared to be the #1 drug for management of alcohol use disorder, and it reduces risk of heavy drinking days. The study also compared naltrexone and acamprosate, another medication which is commonly studied. But what they found was that there are 4 types of alcohol, type 1, type 2, 3 and 4, except type 1, which is stress-related alcohol consumption. Except type 1, either 3 types of alcoholism have better response to either naltrexone alone or a combination of naltrexone plus acamprosate. So acamprosate use gets limited to a specific subset of patients. So in the outcome measures that they reported, that they found that abstinence naltrexone did not have much evidence, time to first drink, but it significantly reduced drinking days, drinks per days, relapse, heavy drinking, as well as significant effect on craving, and had minimal side effects. So after that, a recent meta-analysis done on effect of naltrexone on alcohol self-administration, they found that overall effect size of naltrexone seems to be around 30%. But till recently, a black box warning existed on naltrexone as well as on the LiverTalks website that naltrexone can lead to potential hepatotoxicity and values above. But that is gradually changing. The black box warning has been taken away. The LiverTalks website has also been updated that values above 3 times the upper limit occur in less than 1% patient, and role of ALT elevations are similar to that with placebo, and most of them subside on its own, and there is no clear pathological description of specific injury associated with naltrexone. So when a recent paper studied 2-year alcohol hospitalization rates, that people who had alcohol related cirrhosis, when they compared hospitalization rates, what they found was these middle 2 lines, that people who were given naltrexone for more than 30 days with liver disease had lesser hospitalization as compared to those who were given less than 30 days. So again, saying that long-term use of naltrexone is recommended. When talking about safety and efficacy, we from ILVS have also done studies and presented in EASL as well as ASLD, where safety, efficacy both were established and presented. So naltrexone is, again, in people who do not have liver disease, it is a standard of care, a first-line medications for almost all people with alcohol dependence, and gradually the evidence for liver disease is building up. The other alternate to naltrexone is nalmefene, which is a hepatic safe at all doses, even to begin with, But the problem with nalmefene is that despite an evidence coming from European countries in the last decade or so, unfortunately this medication is not available in India and even in the United States of America. So which brings us to baclofen, the studies which is the medication which has been mostly studied in liver disease patients. A major problem that I found with baclofen literature is that in addiction studies, in alcohol dependence studies, the baclofen anti-craving effects works better at higher dosage. The dosage of up to 120 to 180 milligram per day. So these are the type of dosages which are actually difficult to give in liver disease patients because of the risk of sedation. So what they did, they studied in the paper published in Lancet around 15-16 years back and still remains the gold standard paper in this field, is what they did 148 patients, out of which 84 were randomized. The important thing in this trial profile was this, that almost that people with child C cirrhosis, that this was the patient. They included people with a significantly advanced liver diseases, which was different from all other trials. And the effectiveness they found was especially evident in patients with advanced liver cirrhosis. They also said the other explanations could be more motivated patient. And the reason that it was less studied was that it was not allowed to achieve total abstinence. So the duration was not specifically factored in. Then the Kaplan-Meier survival analysis, the lapse and relapse was better in baclofen as compared to placebo. Even the biochemical markers over 12 weeks reduced, like AST, ALT, GGT, bilirubin, and even creatinine. They found that in the baclofen arm was better. So and after that, another study was done in hepatitis C patients. These were not cirrhosis patients, and found that baclofen was safe. This is one of the largest French real-life experience, a cohort that they have built, in which they keep on publishing papers from, that there is marked reduction in alcohol consumptions in 64 patients, which translated into significant improvement in biological markers and liver functions. So the latest paper that they have put out is the patient outcomes from 104 alcohol-dependent men. Patients, out of which 56% had alcohol-related liver disease as well. And what they found, this was published in British Journal of Psychiatry, and what they found was that proportion of non-lapse and proportion of non-relapse both were better in patients who took 30 and 75 milligram of baclofen. So they did test both low dose. So what they're trying to do is trying to move from just that 30 milligram dose that was discussed in the Lancet paper to another 75 milligram dose. So they studied both and found that in both the group, there were better a proportion or lesser proportion of non-lapse. The percentage of days abstinent was similar in both the groups, but what they found was that sedation or drowsiness was higher, significantly higher. Side effects were higher in people who received 75 milligram, and this they told about the liver disease. They specifically analyzed for ALD patients. So the proportion of side effects were higher with 75 milligram dose in liver disease patients. Now coming on to some quick glance on non-FDA approved medication, starts from sodium oxybate, topiramate, ondansetron, baclofen, gabapentin, varenicline, and metadoxin. We will not go into the details of these medications, except some of them, like topiramate. Topiramate has been known to significantly reduce, based on an RCT level of evidence, that it reduces heavy drinking days. It significantly improves probability of abstinence when continued over 3 to 4 months. But the problem with topiramate, one important side effect that leads to its reduced use, is that it causes hyperammonemia. So in patients who have advanced liver disease and decompensated liver disease, it can become a problem. Ondansetron again was found to be effective in a dose-ranging placebo-controlled trial. It significantly reduced drinking and increased abstinence, but not late onset alcoholic liver disease patients. And because of there was poor effect size, the efficacy trials for ondansetron have not been replicated. So this is the table based on the latest Nature publication last year, where they give these evidences for these medications, starting from naltrexone, where FDA has given, for FDA and APA have given as first line recommendation, except to be avoided in child C, because of, again, possible hepatotoxicity keeps on getting mentioned. And it is allowed with renal dysfunction as well. Acamprosate, they say, is definitely allowed, except if the creatinine clearance is less than 30, or 30 to 50 also is recommended to be avoided. Topiramate also for kidney dysfunction should be avoided. Baclofen, they say, can be given at all stages, but up to 30 milligram. Gabapentin and varenicline, the problem is that the evidence is still building up, so it will still take more time. Last thing that I wanted to discuss today was the depot naltrexone. Since naltrexone oral has been increasingly found to be effective in ALD patients, in addiction settings, depot naltrexone has been present for more than 15 years now. So what it helps is that the advantages is that there is better efficacy because of sustained plasma levels. There is lesser nausea, which is a common complaint in patients when we prescribe naltrexone at peak. So because there are no peak effects after the first 3 days, the nausea is much less. The compliance automatically and adherence becomes better. It becomes better for research and forensics setting because naltrexone remains in the system and there is avoidance of first pass metabolism. Except some disadvantages like injection site reactions, cannot be given with opioid analgesics, higher cost, and it automatically makes people think that they do not have to come for therapy or counseling. So these are the 3 available depot preparations. Unfortunately, in addiction setting, they are being used in a gray zone, not available in India. The CDSCO approval is still pending. So the way it is used is that patients and doctors get them imported on their individual name and then it is used. But it is very commonly used in addiction settings. The reason that there is CDSCO approval pending was probably that a study was being asked, a task group was formed from AIIMS and they were asked to conduct a study, and I think it has been more than 5-6 years that study has not even started there. So these are the available depot preparations. The contraindications are patients who have acute hepatitis or liver failure, patients receiving opioid analgesics, patients with current physiological opioid dependence or in acute opioid withdrawal, individual who has failed the naloxone challenge test, who have previously exhibited hypersensitivity to oral naltrexone. So the recommendations are that you give oral naltrexone for 1 to 2 months, after which you can move to depot preparations. The safety, efficacy, tolerability have all been well established, and they had a significantly lower percentage of heavy drinking days than did placebo recipients, which brings us to the comparison of oral and non-long-acting injectable naltrexone. So this is that the results were similar for oral as well as injectable naltrexone, but there is no trials in liver disease population. So the gaps in knowledge are that most studies reduction in drinking with continued consumption. The Indian population in that way is unique, that impact, because in Western population where these drugs are studied, there are people who are regularly consuming alcohol as part of their lifestyle. In fact, in India and Southeast Asian countries, we belong to a population where alcohol, in a majority of our population, almost 80 to 85% based on latest data, do not have alcohol in their lifestyle. But those who drink heavy. So the type of challenges that we have in Indian population are different, but the support is the family support, the amount of investment family have in patients is much higher. So we expect that response with these medications will be even better in Indian population. Very few studies have they actually end up studying AUD craving parameters in outcome trials. They just decide whether alcohol was stopped or not. But we suggest that craving parameters should also be included. So with that, the algorithm that we use is that all patients with liver cirrhosis are screened for AUD. If they do not have active alcohol dependence, if they have occasional use or in remission, they can just be given counseling or relapse prevention therapy. But if they have severe alcohol dependence, multiple failed abstinence attempts, and once the alcohol withdrawals are managed, and along with continued psychosocial support, in patients who are compensated, first line remains naltrexone and acamprosate. If dual agents, if monotherapy fails among the various medications that we discussed, and if still there is no improvement, then we consider disulfiram based on risk benefit in a case-to-case basis. Patients who have had recent decompensation, the first line remains baclofen and acamprosate. The second line remains gabapentin. Nalmefene unfortunately is not available. And those who have comorbid kidney dysfunctions, it is recommended to avoid acamprosate. So some take-home points for everyone. Please remember that the duration of treatment in almost all addiction studies, even after 5 years of abstinence, the risk of relapse remains 10 to 15%. So duration has to be long-term. These are chronic relapsing illnesses. But we know that pharmacological therapy increases probability of alcohol abstinence compared to placebo by approximately 30%, but it should always be combined with psychosocial interventions, erroneously yet commonly known as counseling. Thank you.